do I have the control? I think so I can move
No,
it.
you'll have to tell Marty when you need to change the slide.
Okay. All right.
Thank
I
you.
apologize for this thing. But anyways, the topic I'm going to talk about is the evolving role of HEOR, health economics and outcomes research, and in our ever-changing healthcare system. Next slide, please. So I'll briefly discuss the history of economic evaluation. I think so it's very important when you're looking at the future to look a little bit, reflect back to see where we have come from. I'll talk about the ISPOR top 10 trends. And then I'll spend most of my presentation time to discuss a few key healthcare change drivers. And then hopefully we'll have some time for discussion. So as you can see, our field, I won't say it's relatively young, but the first economic analysis was reported way back in the 50s and the 60s. But it was in the 70s when the word pharmacoeconomics was actually coined, and economic evaluations were then conducted or reported in the pharmacy field. Now, the global push really started with the formation of the International Society of Technology Assessment in Healthcare. And this was in 1985, to be specific. And the mission of this society was to actually encourage the research, education, and exchange of information concerning the clinical and social implications of technologies that are used in the healthcare system. And of course, the optimal use of these technologies. So at that time, there were around 400 members representing 30 countries, and they were from very diverse backgrounds, from economics to healthcare to psychologists. Now, I think this led to the creation, or this was a stepping stone for the creation of the HTAs. Of course, first in Australia in '92, followed by Canada in '93, and then the UK in 1999. And around this time, the United States Public Health Service also established the panel on cost effectiveness in health medicine in the 90s. And of course, one of the biggest things that happened around that time was the US FDA passed a Modernization Act in 1997. And among other things, this act allowed drug companies for the first time to provide economic information about their products to formulary committees or managed care organizations, or even large-scale buyers of healthcare products. And then fast forward to the 2000s, Health Technology Assessment International was formed. I mean, of course, this is still going strong. It's a scientific and professional society which encounters HTA and provides support for optimal policy and decision making. And in the United States around that same time, the Academy of Managed Care Pharmacy launched the Formulary Dossier, which provides guidelines for clinical and economic analysis. Now, if you look at this trend from the 50s all the way to the 2000s, the discussion on value really started picking up in the 90s. Next slide, please. And so in this slide, this is more US-centric. This presents basically a transition of managed care in the United States, again, from the same 70s to present time. And as you can see, in the focus area, or the first row, in the 70s, the focus was clearly on administrative efficiency. Excuse me. And then as it evolved over time, the focus shifted to unit cost management, pharmacy cost management. Then we started talking about healthcare cost management. And then finally, in the 2000s, the focus was on outcomes management. So you can clearly see how this field has evolved in the last 4 or 5 decades. Now, the second row where, I've listed the administrative fees, that actually is, how were these focus differentiated? So in the 70s, it was more about administrative fees. But as you move forward in time, they were talking about drug plan savings, outcomes evaluation management. And if you see the 2000s, that's where we started really talking about value assessments. And if you look at the elements of success over time, that's the last row, again, in the 70s, we were focusing more on claims processing. And as you move forward, formulary management, and to the 2000s and present, we're talking about pharmacoeconomics, we're talking about predictive modeling, outcomes management, disease management, artificial intelligence. So these are some of the things that we have been discussing now. So this should, for those of you, especially the students, who are listening, the last two slides, this slide and the last one, should give you an idea of how this healthcare or health economics and outcomes research field has really evolved from being very narrow focus on just cost or unit cost to really this whole pivoting towards the whole value framework, value assessment. So next slide, please. So in the same line, moving to present times, here is the top 10, HEOR trends that ISPOR publishes every year. So in 2020, there is no surprise to see, drug pricing, price transparency, and alternative payment models as some of the, top trends. Also included in the top trends are, novel curative therapies, precision medicine. Now, there's a couple of trends like, the universal healthcare coverage. I think so that's more American than global, or at least, most Western Europe, Australia, Japan. I mean, they have a single payer system. So I don't think so the access and equity aligns much with the global trend, but the healthcare spending clearly is at a all-time high in the United States, is a lot more than other countries. So if you look at these top trends, some of the, and if you look at the last 3 or 4 years that ISPOR has published, drug pricing, curative therapies, precision medicine, they have stayed in these top 10. So what I'm going to talk about next is, in the interest of time, I'm going to just focus on some of the key change drivers that I feel are not only impacting currently, but also going forward the next 5-10 years. These will continue to dominate a lot of the discussion in the HEOR space. So again, new technologies. When we talk about innovation, we talk about technologies, and technologies include curative treatments, they include precision medicine, they include digital health as well. These are truly driving change in the healthcare system. And they are influencing the way diseases are prevented, the diseases are diagnosed, and diseases are being treated. And the whole concept of drug pricing, or I should be more specific, I should say the whole concept of value-based drug pricing, which is based on, the customer's perception of, being unique or having highly valuable features. These are tied, the drug pricing is tied to that innovation. And the way I see, the future changes in healthcare, these will relate to two things. One, technology. And when I say technology here, I mean robotics, machine learning, artificial intelligence that we have started using in our clinical decision support. And the second one is maybe the way we organize and deliver healthcare. And the newer innovations would be, telemedicine, digital health, maybe, redesigning the whole concept of hospital redesigning. And finally, the fourth piece that's there on the slide is the shift from treatment of illness toward, prevention and sustaining health. So, the next few slides for me, I'll be focusing mainly on these 4 change drivers. So let's talk about the first of the 4 change drivers, and that's the innovation. So here I've included precision medicine. And as you know, the focus of precision medicine is on identifying, which approaches will be effective for which patient based on, say, the genetics or environmental or lifestyle factors. Now, with precision medicine, and if you couple that with value-based care, they have been playing an increasingly important role, right? Both of them. And because of these two functions, I would say the HEOR is no longer considered, a support function, but it's actually transitioned to becoming playing a more central role in the pharmaceutical industry. And with the introduction of treatments such as CAR-TG, Luxturna, which is used for retinal dystrophy, Zolgensma for spinal muscular atrophy, and then CFTR modulators, which are used in cystic fibrosis. I mean, these have been a game changer. These are truly innovative products. You know, when I talk about innovation in my class, I always use an example of Apple iPhone 1, which was truly a game changer. It changed the entire, phone industry and the way we communicate. But iPhone 12 and 13, are they truly innovative? I don't think so. They are Me Too products. But again, CAR-T, Luxturna, Zolgensma, I mean, these are truly game changers, truly innovative product. Now, with the introduction of these novel curative treatments, what has happened in terms of data science? So clearly there is an increase in genome-based technology platforms. So, with COVID, we have been talking a lot about RNA. So assays for RNAs, proteins, metabolites. So they have been increasingly being used to classify disease states, whether they're used as diagnostics or even as prognostics, to predict any future clinical outcomes. So these testings, coupled with the increased use of electronic medical records and EHRs, medical imaging, hospital and digital health data, what they've done is they have really necessitated the development of standardized methods of data aggregation. And then when you do data aggregation, that's an opportunity for us, to work with different types of data. But also you have to keep in mind that it presents some challenges. So, the security of the data, the confidentiality, if you're sharing data across stakeholders, and of course you have to have the capacity or the infrastructure to kind of hold the data. But keeping that aside, I think so standardization of data aggregation methods is the key, opportunity for us in this space. And then the cross-disciplinary translation of emerging computational techniques, such as machine learning, natural language processing, or even artificial intelligence. I mean, these clearly are, the way we are moving forward with how we are using these diverse data sets to really come up and create more efficient and sustainable models of care. Now, as an example, there is a startup company in UK which actually is using, unsupervised AI algorithms, and they're using it to identify patient cohorts for drug discovery, clinical trials, for real-world evidence studies. And they're using some kind of a machine learning-based software which scans the entire electronic health records and unstructured doctor notes, and then they are able to find the right patients based on phenotype. So again, one of the messages for the students is to really start, looking into some of these newer techniques and starting building skills in these areas. Next slide, please. So moving on, the second, change driver for me has clearly been the drug pricing. I mean, I don't know. I mean, in Europe, I know there's a lot of, reference pricing. In Australia, the PBAC does a lot of these decision-making. NICE does in UK, and then, the health ministry in Japan. In the United States, because the way our healthcare system is set up, clearly, I mean, we have so many different payers, and there's a lot of discussions of rebates and discounts. However, as the newer drugs, the more innovative drugs are being introduced, which are, which have unique characteristics, which actually meet the unique needs of the patients, and they have a certain, dynamic in terms of the competition. Pricing models have also evolved over the years, and they have really been nuanced to reflect these unique product characteristics. So if you have to balance the increased drug prices, clearly, pharmaceutical companies have been experimenting with, different price models. And so what I present here are, 4 models, but clearly there are more than 4 models that are out there. But I thought these were some unique and interesting models that I can discuss very briefly. and talk a little bit more about each of these. So the first one is the risk-based model. And I was a graduate student when I actually heard about Januvia and the risk-based model, outcomes-based model that the company had launched. And I was so fascinated by this whole model. And of course, the risk-based model was introduced mainly for specialty drugs, orphan drugs. And I think so in Europe, having a single payer system, they have really negotiated with the drug makers to participate more in these type of risk-based or outcome-based contracts. And then other countries have also followed suit. But the second model, which is the subscription model, or it's also called the Netflix model, this novel approach, it offers an all-you-can-treat arrangement for purchasing drugs. And it's interesting, this model was actually pioneered in Australia for hepatitis C drugs. And what it does is this model lets purchasers pay a set amount for unlimited patient access to a specific product for a given amount of time. And so in the United States right now, 2 states, I think so, Louisiana and Washington, they have been negotiating with a pharmaceutical company using similar type of arrangements for hepatitis C drugs. The third model is the mortgage model. And as we all know, we are buying these houses and we are paying mortgage over 30 years. So similarly, products that don't have any direct competition, so that means, they can enjoy the long-term, in the long-term stability in the market and don't get easily switched. So those that don't have direct competition, so these will be new immunotherapy products for oncology, orphan drugs for rare diseases, or even the emerging, cell and gene therapies. These are good candidates for mortgage models. So what this model allows is, it allows the purchaser to spread the cost of the expensive therapy over a period of time, as opposed to requiring them to, make a full payment, one-time payment upfront. And the last one is, again, is pretty common. These are called the indication-specific model, and these models are used especially for products that have multiple indications. So again, TNF drugs, such as Enbrel and Humira and Remicade. I mean, these are used not only for different musculoskeletal disorders like rheumatoid arthritis, psoriatic arthritis, or ankylosing spondylitis, but they're also used for Crohn's and ulcerative colitis. So, indication specific is, they are approved for a specific indication, and a specific pricing is attached to that indication. And sometimes, the payer may decide against covering a certain indication, whereas, allowing another indication of the same drug to be covered by a health plan. So it's kind of interesting. So why am I talking about drug pricing and pricing models? So one of the things that is common in all these models is, of course, data. And to successfully navigate different value assessment framework in the global market, we need to include, including price negotiations. Companies really need to become more sophisticated in their use of healthcare data to support, negotiations and demonstrating the value of the product. So again, for the students especially, learning the different models and how do you generate these data and how can you successfully build these models would be an exercise. Again, some of those things that we sometimes don't teach in our, at least in my program, we try to bring in speakers from the industry, but I would say these are some of the unique skill sets that you can really build over time to kind of, help prepare yourself for the changing, healthcare needs going forward. Next slide, please. So this, this slide, I'm sure most of you should be familiar with. I just added, what type of data that I'm talking about when it comes to, supporting different HER functions. So, we talk about the preclinical phase, we talk about the clinical phase, we talk about the post-marketing phases. And a number of types of data are generated to support reimbursement structures and to identify, successful interventions. So you can have pilot data in phase 2, you can have burden of illness, starting in the preclinical phase, budget impact models in phase 1, phase 2. You can have economic models, pretty much throughout the different phases. And of course, in your post-marketing surveillance, you can have longitudinal databases, PROs, different drug utilization measures, disease management, real-world evidence. So again, you can see that these are the data that can really help guide healthcare coverage and access decisions. These can help pharmaceutical companies to close the gap between clinical trial and real-world health outcomes. We can even, do a lot of subgroup analyses, target specific populations. And finally, these data allow pharmaceutical companies to communicate the value of their innovations, which is actually the ultimate goal, right, for most of these models and for most of the data that we are collecting. So again, this just very nicely summarizes, the different data sets that probably, you should be familiar with. Next slide, please. Now, I want to draw your attention to, one such data technique that is being used to demonstrate the novelty of new treatment interventions. So again, everybody's familiar with standard techniques such as cost effectiveness analysis, which measures the treatment benefit in terms of expected life years or quality adjusted life years gained. However, this approach ignores the gains which derive from the possibility that a health technology allows an individual to survive long enough to benefit from other technological innovations which raise life expectancy or quality of life in the future. So, just think about, our parents, grandparents, their life expectancy and what, if they were vaccinated or not vaccinated, say, when they were a child and how long they lived. And we are living longer and we are actually taking advantage of the new innovations right now, which is further extending our life. So you can have that, analogy. So the concept of real option value is particularly important in disease areas where the main goal of treatment is life extension. But there's also one more requirement, that the rate of innovation in this disease area has to be rapid, meaning, if the rate of innovation is not there, you live for a certain amount of time, but then you don't take advantage of the next innovation, right? So that it has to be continuously, innovation has to be there. And there have been some disease conditions like the chronic myeloid lymphoma, metastatic melanoma, and breast cancer that actually, the goal of the treatment has been life extension, but also the rate of innovation has been rapid. In fact, research has shown that the option value adds about 10% of the conventional net monetary benefits of technologies in CML. And in breast cancer, it was a little bit higher. It was 25% to the conventional NMB. So again, the message would be newer techniques and clearly focusing on really adding on some new ways of quantifying value and showing the overall value of the treatments that we are using. Next slide, please. So the third change driver that I'm going to discuss is digital health. And then again, many people forget that, in digital health, actually EHR is a part of digital health, but, we automatically think about telemedicine and especially mobile health. So mobile health, again, it's interesting, it includes apps that are focused on wellness and prevention, but also on condition management. What digital health has done is actually it has improved the quality of care. It has increased patient engagement. Of course, there's a lot of convenience in terms of how you record. And then there's a lot of data that has generated, which has spawned the whole healthcare analytics around digital health. There's some statistics that in Europe, more patents have been granted to medical technology, over 14,000, close to 14,000 compared to pharmaceuticals. So that's an interesting trend, over the last couple of years. Now, what do we have to keep in mind as digital health becomes more and more mainstream and we start standardizing the methods of measurement and assessment? So one of the things we have to keep in mind is the traditional methods are pretty much limited given the uniqueness of these interventions. So, I mean, it's very hard to kind of perform randomized clinical trials with a mobile app, or there could be issues of interoperability or user friendliness, or it may take some time to develop the process of evaluations. The other aspects of digital technologies, which maybe when we use traditional HTA methods, which may not be addressed for digital technologies, may be access. It's not everybody has the technology in hand. I mean, you can have the LMIC or the low middle income countries versus advanced countries, even within the advanced countries, depending on having access to smartphones or to digital technology could be different. So access, equity, patient empowerment could be some aspects that may not be addressed by traditional HTA. So when you are kind of creating a model of evaluation, you need to factor these things. Now, one more thing I want to make it very clear that digital health it does not necessarily mean that we're going to replace clinical decision making. I think so. It is going to make clinical decision making a lot easier and a lot more effective. So that we need to be very clear about. It's not going to replace for sure. And the value of digital health will not only depend on the clinical and economic aspects, but I think so it will depend on the technical features, the perceived benefits for different stakeholders and also the end users, mostly the patients. But also one more would be the health system's own capacity to benefit from this innovation. So, again, a lot of opportunities in the digital health space, but again, there's a lot of standardization still needed in terms of how do we conceptualize these different methods to kind of build up a framework to bring these technology in the mainstream. Next slide, please. So work is already going on in terms of, I told you one of the challenges was, having randomized clinical trials. So I was looking up at some of the mobile apps and looking at if these have been tested under randomized clinical trial conditions. And so there's an app for atrial fibrillation. This app actually integrates clinical decision support, education, and patient involvement strategies. It has been shown to significantly improve knowledge, drug adherence, quality of life, and also anticoagulation satisfaction. And so, there are other apps, the Digital Diabetes Prevention Program, adherence to inhaled steroids in patients with asthma. So clearly the move is now trending towards kind of standardizing the method, improving the way we assess. But again, there is a little bit of challenge still in terms of how we conceptualize, but definitely we are on our way forward. Next slide, please. The last change driver, which it's interesting in the last 1 year, what we have seen with the pandemic and the vaccination. I mean, this has really brought prevention to the forefront. And we have all the evidence in the world to point to, spending on prevention is as good value for money as you can hope for. And again, very briefly, the prevention, when we talk about the primary prevention, the secondary prevention, and tertiary prevention. And in my next few slides, I'll focus mainly on the primary and secondary prevention. So next slide, please. So if you look at the whole economics of prevention, it is surprising to see that most of the OECD countries, they're spending close to 2.8% of their health spending is on primary and secondary prevention. And so, immunization 9%, early disease detection, which is secondary, is close to 7%, health condition monitoring is 44%, education and counseling, preventive immunization screening, 27%, collective services such as information campaigns, epidemiological surveillance, 13%. So, but again, you have to put in perspective, 2.8% of health spending is for prevention. And look at how much tertiary prevention gets, 80% of health expenditures. is devoted to tertiary, which includes curative and rehab services. That's around 60%. Pharmaceuticals is around 20%. Now, keep in mind, some pharmaceuticals are also primary prevention, but 20% is allocated and then you have around 13% for health expenditure, and health system administration is 3%. So clearly, this doesn't add up. We talk about prevention, but we spend less on prevention. Now, this, I don't know if you can see the different countries, OECD countries. The average healthcare spending is around 2%. And two countries, Canada and then UK, in the leftmost corner, you can see that their spend is clearly pretty high. Canada is around 6%, and then UK is around 5%. The rest, they are pretty, up to 3%. Some are maybe closer to 4%, and then Australia is somewhere around, averaging is around 2%. So, when you think about prevention, and next slide, please, you also have to then think about, okay, is there any effect of, economics or, financial crises? And this data is a little bit old, but it's very interesting because it captures a time when we did experience a major financial crisis in 2009, 2010. And if you look at that time, inpatient care, outpatient care, there was not much of a change. But if you look at pharmaceuticals and prevention, clearly they were affected more by the economic crisis. So again, this goes to show that, when there is a resource allocation decision, somehow prevention takes the back seat. Now, there are ways where we can use the resources very efficiently. Next slide, please. And we have I have a couple of examples. Now, I did not include one specific information on this slide. Prevention, especially targeting high-risk population with diabetes. So that thing that I did not include. But if you look at this cost-effectiveness ratio for different population, high-risk population with diabetes, all 35 years old, if you look at the prevention and cost-effectiveness ratios, around 130,000 per quality. But if you look at 35-year-old with hypertension with diabetes, 87,000. And if you look at 75-year-old with hypertension with diabetes, it comes down to $32,000. There's one more example that I'm going to use, is of the next slide, please. Is that of cost effectiveness of colorectal cancer screening. And if colorectal cancer screening, these depends on two things. One, the technology that we use, so colonoscopy, sigmoidoscopy, or fecal occult blood testing, and then how frequently the screenings are administered, right? So there are two factors on which the cost effectiveness ratio will depend. And so if you increase the frequency of the testing, it increases the effectiveness, right? So the proportion of cancer cases detected early, and of course, you'll have a number of qualities saved. But generally, if you look at, what's the diminishing marginal returns, of course, and there are less favorable cost effectiveness. So you have to decide a threshold at which, you decide, which testing and at what time period. So again, the point of showing these two examples is that, we can allocate resources much more efficiently if we can start looking at, where the return on investment is the highest. So prevention doesn't have to be that everybody has to be vaccinated. Of course, we have heard of herd immunity, right? 80, 90% getting vaccinated. And so, the whole idea is to, when you're conducting these, economic analysis, making sure that, you're focusing on the right questions. Now, when it comes to, one more point I want to make, to make sure that I'm very clear on economic analysis of preventing services is, there are a couple of questions you do need to ask, which, when it comes to, curative treatments or new technologies, we don't even think about it. It's automatic, it's a standard. But when it comes to prevention, one of the key questions you need to ask is, what is my choice of comparator? So what are you comparing against? See, that's a key thing that you have to keep in mind. Then again, what's your perspective? Are you looking at the societal perspective? Are you looking at a particular healthcare perspective? Are you looking at a health system perspective? And then, you also have to think about if preventative services are used, the lifetime healthcare cost actually will rise because people will live longer. So, say for example, smoking cessation, people live longer, so they may use a lot more resources, which they wouldn't have other if they had not utilized any of those interventions. So again, when you are conducting any HEOR studies and you're focusing on some policy issues around prevention, I think so these are the points that you need to keep in mind as you build these studies. Next slide, please. So finally, one of the things I always ask when it comes to any intervention is scaling. When it comes to prevention, okay, we did an evidence-based prevention and it is shown to be cost effective. But can we replicate these evidence-based programs that the research studies had shown to be effective? Can we replicate it? Can we increase the scope? And of course, to ensure long-term sustainability of these interventions, evidence-based prevention, you need to really keep in mind the theoretical conceptualization versus how you're delivering these prevention programs. Then again, building community capacity, building partnerships among stakeholders. I mean, these are things that we never learn, but as we are building and scaling up these programs, you need to keep in mind ongoing program assessments, including economic analyses of prevention programs. And finally, in providing support to key stakeholders. And support could be data management, data aggregation, assessments. It could be a lot of these factors, and that's one way where we can really help build these, the scalability of these interventions. Now, it's not easier as I just make it sound. There are challenges to implementation. The challenges clearly is, the cost effectiveness when you're doing on a study-based and then you're trying to scale it to a community-based or real-world implementation, you may have some unreliable cost effectiveness estimates. There could be challenges of health inequities. And of course, I can again bring out the pandemic and talk about the vaccination and the inequities that we have seen in our society. And so that also tells us that we need to really develop or build health equity metrics. We need to explore them. The other ones is ethical issues, when you talk about, and again, I can think about HIV testing in terms of preventive services, talk about confidentiality, counseling, voluntary participation. And again, Hep C drugs also, when we have voluntary participation in administration of Hep C treatments, the ethical issues do come up. And finally, the contextual problems also need to be considered. The contextual problem would be, the micro, the meso, and the macro scale. So what a micro, you think about number needed to implement, that will be at the micro scale. But when you think about the health system as such, that will be the meso. And then when you're looking at the national regulatory or policy level, that would be the macro scale. So in what context really do you want to implement, your preventive services? So again, these are things that will be challenging, but I guess if you're aware, if you know your methods, I think it'll be easier to kind of move forward in kind of implementing it in the system. So in summary, I mean, if you look at what I basically talked about was some of the key change drivers. There's a lot more clearly, but some of the key change drivers of healthcare and how these drivers are actually interconnected. They overlap to a larger extent. But again, this is a tremendous opportunity for students and researchers in this space to kind of develop these key skill sets in these emerging areas. And as I mentioned earlier, I mean, HEOR is really moved from just merely being a support function to really playing a more central role in the pharmaceutical companies. And it all bodes well for us as we hone our skills and really prepare for the future changes in the HUR space. So hope it meets the objective of the symposium. And at this point, I would open it for any discussions or questions that you may have. And again, I would like to thank again the organizing committee for inviting me.
Thank you so much, Professor Kamal. That was just a fabulous speech for us, and we really appreciate it. We've got a few questions. We've got some great questions here. First one's from Clara. Is it feasible to promote healthcare expenditure in prevention in healthcare systems that rely on private payers such as the US, as it is in countries with more public healthcare funding? What are the different challenges to increase funding for prevention dependent on the setting?
So that's a very interesting question. I mean, that's that is clearly a distinction between a public healthcare system versus a private healthcare system. However, I would say that looking at the changes, especially in 2010, and I'm going to talk a little bit more about the United States because it seems like United States is a little bit of an anomaly when it comes to the world healthcare system. But 2010, when we signed the landmark Affordable Healthcare Act, where we kind of thought we were moving towards universal healthcare, and we did. I don't think so. The law has been struck down. There has been numerous attempts, but it has stayed on. And I firmly believe that I think so as citizens, when we get used to certain things, it's hard to let go. And I feel people have realized what universal healthcare can do in terms of really accessing and affording. But the reason why I'm bringing up Affordable Healthcare Act is one of the provision was, pre-existing conditions, preventative care. And in fact, I clearly remember our preventative care actually was $0 after that. We didn't have to pay the annual checkup. The copays were $0. And so the question is pretty fair in terms of, the changes to maybe 10, 15 years ago. But I think so the United States clearly sees the need to invest in preventative care. The implementation is slow, because I would actually bring up one more area, which I didn't touch upon. I would have loved to touch that, but it's a whole area altogether. It's called behavioral economics. So you can have a lot of policy, you can have a lot of incentives, but will people change their behavior to take advantage of those incentives? So again, going back to the example of COVID, we saw there were people who, the diffusion model, right? Some are early adopters, they got vaccinated very quickly, and some are late adopters, and some are never believers. So the bottom line is, I think so. There is, as I mentioned in my talk, there is value to prevention. We have all recognized that. I think so. We are investing in our health. The last 1 year has taught us how much that's important. We've started really, and I think so. In terms of United States and also some other countries that I know I've interacted with people, there is a definite investment in the preventative services. So I definitely see going forward a lot of investment. Plus, I think so. The majority of talk might focused on key change drivers and innovation. I think so with the apps that we have, I think so it has really made all of us pay a lot more attention. Like I have my, the Fitbit, right? And then, how many steps? I never would count that. but so I think so slowly, step by step, it won't change overnight, but hopefully the different systems will take into account the benefits of what these services have to offer, and hopefully, will make a big change in our healthcare system. I hope that was what the question was.
That's fantastic. Thank you. I'm just going to try and squeeze one more question in. We've just got a couple of minutes. This is from Tan. How do we prioritize or balance the importance to address and value health equity when innovation continues to drive better outcomes for population who are already users of service and healthcare? compared to those with greater disease burden who are unable to afford or find it difficult to access healthcare?
You know, Tam, that's an excellent question, and I would actually bring up one example since I'm very active in ISPOR. Maybe 7 or 8 years ago, I had a colleague who's now retired. You know, he was the ethics equity person, did a lot of research in that space, and I was the economics guy. Although I am not an economics guy, but they would call me. And we had done a paper on ethics and economics, equity and ethics and economics, social justice on that part. When I went and I presented that at ISPOR, there was not much of a discussion on equity, social justice, ethics. But this past year, there is a special interest group that is now focusing mainly on equity and ethics. So, you know, to answer your question very shortly, I mean, it has taken all these years for ISPOR to realize that it's just not cost. It's just not patient outcomes. There are other important social determinants that we need to include. And other countries, I think so, because of the way the healthcare system is set up, you know, universal care, access to all, I think so they are much more prepared to address this question than the United States. Because in the United States, I mean, I can go on and on this topic, because even within the healthcare system, say, for example, you know, Medicaid or Medicare, which are government-run programs, there are disparities in terms of physicians refusing to see these patients because, you know, the reimbursement is higher for private patients versus you know, patients who will come from government programs. So how do we prioritize? I think so, you know, me and you, I mean, you know, pharmacists, and again, I'm a pharmacist, and I always remember, you know, when I was in pharmacy school, we never vaccinated, right? And now looking back, we are vaccinating, and I'm thank God we are vaccinating because, you know, in COVID, we were able to step up and do our, and what it does is advocacy. I think so that's the key part. And with ISPOR starting that, you know, equity and ethics SIG, that's an important step forward to really start a dialogue and start making those change, you know, those hard discussions. And slowly but steadily, I think, you know, we'll come around and we'll really recognize that this is an extremely important area that we really need to tackle, because how can we really discuss health without considering the equity part? I mean, you know, that just doesn't add up. So, you know, we need to have these groups come together and there has to be there has to be a system-wide change in terms of how we think. And one of the other things, and it may sound a little more controversial, but I do talk about this, and I know in the end, this is more from a United States perspective, we always say patient is in the middle of the care. No, they're not. As simple as that. And this is one issue that is tied to bringing the patient back into the middle of the healthcare system and truly making it a patient-centered healthcare. If we don't have equity and ethics in there, I don't think so we will ever achieve that. You know, again, I mean, I don't know if Tan wanted some specific stuff. I know my answer was more general in nature, but I think the good part is with what has happened in the last year with COVID and all the inequities that were exposed, people have really started paying attention. And I see this changing tremendously going forward. So I'm very positive about it.
Fantastic. That was a really fabulous answer. Thank you. And a great question. A huge thank you to you, Professor Kamal, for such a comprehensive and interesting keynote speech. We're really grateful for that. And everyone, please remember, you'll need to log into a new Zoom link for each of the workshops, and we look forward to seeing you there. Thank you so much, Professor Kamal.
Thank you again. It was a pleasure. And again, I know it's morning, so have a great day. And I don't know, I know it's still 8 o'clock over here, so I might just get a quick dinner and may join in one of the sessions.
Fantastic. We hope you can.
For sure. So take care and good luck.
Thank you. Thank you very much. Really appreciate your time.
All right. Bye-bye.